That's great. Thank you, and good morning, everyone. Welcome to today's cyber seminar. This is Dr. Robin Masheb, Director of Education at the Prime Center of Innovation at VA Connecticut, and I will be hosting our monthly pain call entitled Spotlight on Pain Management. Spotlight on Pain Management is a collaboration of the Prime Center, the VA National Program for Pain Management, and the HSR&D Center for Information Dissemination and Education Resources. Today's session is perioperative buprenorphine management, and I'd like to introduce our presenters for today, Dr. Thomas Hickey, who is staff anesthesiologist at VA Connecticut Healthcare System and assistant professor of anesthesiology at the Yale School of Medicine. Also with us is Dr. Caroline Falker, who is medical director of the Homeless Patient Aligned Care Team at VA Connecticut Healthcare System and instructor at the Yale School of Medicine. Our presenters will be speaking for approximately 45 minutes and will be taking your questions at the end of the talk. Feel free to send them in using the question panel on your screen. If anyone is interested in downloading slides from today, you can go to the reminder email you received this morning and you will be able to find the link to the presentation. Immediately following today's session, you will receive a very brief feedback form, and we appreciate you completing this as it is critically important to help us provide you with great programming. And now I'm going to turn this over to our presenters.
All right, well, thank you for the invitation. I'm delighted to be here, and not only to share the stage with my excellent colleague, Caroline, but let me just quickly shout out another great VA organization that kind of kickstarted this whole perioperative buprenorphine project we've been working on, and that is the VA ECHO Pain Opioid Core Medication for Opioid Use Disorder in the Perioperative Care Settings Work Group. So a big mouthful, but it was a lot of fun to work with that team and a very productive collaboration. A lot of what we'll talk about today was developed in that group and published in a Medical Clinic of North America article last year that you could find. I've practiced this. It's about 20, 25 minutes, so I promise it won't go beyond that. There we go. So the obligatory outline slide, just briefly. I imagine there's a lot more experts in the audience about some of these elements. I have a little more experience in some others, particularly the acute pain, multimodal analgesia arena. And then we'll bring it all back home and talk about where buprenorphine might fit into that. I couldn't resist adding a few slides on Sublocade. And then we'll turn it over to probably the more engaging part, which is Caroline's part on case discussions. This is data that was recently downloaded from the CDC's National Center for Health Statistics website. And suffice it to say that the opioid crisis, just despite a lot of valiant efforts, including by many audience members here, just is a terrible problem that just gets worse and worse. Surgery plays an important role. So this is getting increasing attention, including by surgeons, importantly. But the bottom line here is surgery has an important role to play in the crisis. There's a lot of surgery going on in our country and worldwide. A lot of opioid prescriptions are written after surgery, as you can see here and elsewhere. And one bottom line takeaway from surgery is that surgery is painful, and opioids have an important role to play. And until we find something better, they're going to continue to have an important role to play in the treatment of pain after surgery, but clearly at a cost. As you can see here, we're going to talk a little bit more in an anecdote that's coming about total hip arthroplasty. And these authors found that at a year out, as many as 16% still taking opioids. And as you can see from the second bullet, if patients are on opioids to begin with, as you'd expect, their likelihood of taking persistent opioids post-op is markedly increased. So let me give you some context to this slide, and then I'll explain the quote. So I graduated from my anesthesia residency in 2015 at a reputable place in Boston. And at that point, we were still taught to recommend to patients undergoing significant surgeries where at least moderate pain were to be expected afterwards to abstain from buprenorphine 72 hours, okay? Due to the theoretical risk that there'd be so much blockade of full agonists like the oxycodone, hydrocodone, morphine, fentanyl, et cetera, that the pain management would be very difficult. So shortly after I arrived here at my first job out of training, We had a patient show up for his total hip arthroplasty, having taken his buprenorphine the previous day. So the anesthesiologist said, "We really can't do it because I think your pain's going to be so bad afterwards." And then the patient entered into a planning process for the next surgery, which did take place after the recommended 72-hour abstinence, and across the board was very difficult. The planning was difficult, the patient was frustrated, the wife was frustrated, the surgeons were frustrated, the surgical coordinator was frustrated, and the outcomes weren't great either. The patient had overuse of his Dilaudid prescription post-op, overused his buprenorphine, both of these for the stated reason of poorly controlled pain. So by any measure, length of stay, pain scores, opioid consumption, patient satisfaction, and especially communication between the different providers, namely the acute pain people like me and the prescribers, it was a fail, a bad fail. So the surgeon just said, "I don't care what y'all do, just do something so that we're all on the same page." And that's what the quote is. So what we did was come up with a strategy. So I don't want you to take away that this is a correct strategy. In fact, we'll I think arrive at a consensus that it's not a correct strategy. But this not long ago was our strategy, 2016. So bookmark this moment in time. At this point, we're still recommending a 72-hour abstinence from surgeries where moderate or greater pain were to be expected. In other words, surgeries where we're going to expect to have to prescribe some amount of full agonist opioids to manage pain. We're going to get back to this just a few years later. It was going to change pretty dramatically. So a few slides on acute postoperative pain. So the bottom line here, again, to reiterate, surgery is painful. For some people, it's the most pain they have in their life. Patients recall a lot of pain after surgery, as you can see from these surveys, and experience a lot of distress about that pain. These show, this was a random sample of patients who'd recently undergone surgery, that not much changed between 2003 and 2013. And if I had to guess, if they do another one, there was some author overlap here. So if they do another such study, it probably won't be much change in 2023, unfortunately. Who else cares about it? Well, we should. As you can see here, the bottom line here is that bad pain after surgery leads to chronic pain after surgery. And chronic pain after surgery is common, even for surgeries that we would consider to be benign, such as inguinal hernia repair. It can even lead to pretty significant disability. So I want to just touch on multimodal analgesia as a concept. It means just what it sounds like, multiple agents with multiple mechanisms targeting pain. Why would I single out this big three? Well, there's this study at the bottom. This was a 2016 guideline for post-op pain management. And every possible society under the sun that has anything to do with acute pain was in on this study. And they made 32 recommendations, and only four of those 32 were considered to be supported by high quality evidence. And that's where I get the big three. So number one, multimodal regimen. Number two, Tylenol and NSAIDs in particular. Number three, regional anesthesia, which I mean blocks. For those of you in the audience who've had, say, a knee replaced or your shoulder operated on, hopefully you were offered a numbing injection by us to numb your surgical site. And then the fourth was to consider epidurals for major thoracic or abdominal surgery. So for most surgeries, if we can get patients these big three, it makes a big difference. Well, where does buprenorphine fit in? Well, I think there's a little history anecdote here that's kind of fun and a little surprising to me, that buprenorphine was actually an accidental discovery in the 60s as a result of a push to figure out an over-the-counter replacement of a codeine drug. All right, over-the-counter opioid, seriously. Safe, over-the-counter opioid that had minimal addictive properties, but still treated pain well. So I think a lot of us, particularly in my business, have lost track of the fact that this was really discovered to find a good analgesic drug. And it is approved for that indication. All right, you all know better than me the properties make it useful in opioid use disorder, but I'll just briefly do my sort of poor man's description of them. Partial agonism, we think of it as a partial agonism because it doesn't create a maximal response. And if you have this long duration buprenorphine hanging around, clinging to the mu opioid receptors, which it does with high affinity, and then we give a full agonist opioid, let's say heroin, we expect there to be a strong attenuation of that heroin effect, which would be a maximal effect, a full agonist. And there it's effectively acting as an antagonist. So if you have this buprenorphine hanging around in a patient providing analgesia, mitigating withdrawal symptoms, blocking reward, and minimizing craving, that's kind of the sweet spot we look for. All right, so buprenorphine and acute pain. I'm going to spend about 4 or 5 slides just reviewing some trials, some data, away from the theoretical down to the nitty gritty to review its role in acute pain and also acute pain treatment in patients on buprenorphine. Some of these are low quality studies, but it's all we had at the time, and some get to more of the randomized trials that would actually tend to change our practices. And you know, the takeaway from these next series of slides is they started to get people like me, who were trained to really live a little bit in fear of buprenorphine, to maybe not live in fear of buprenorphine, and maybe even think that we could take advantage of its analgesic properties around the time of surgery. So I'm not going to go into huge detail on these. I'm just going to give you the bottom line for each of these studies. So this one looked at cancer patients chronically treated with buprenorphine for their pain. They present with breakthrough pain, and guess what? Morphine works just fine in those patients, safe and effective. Okay, another one. So parturients. So these women, they can't plan exactly when they're going to have their delivery, obviously. So they kind of presented a nice little area of study for buprenorphine. They're on buprenorphine for opioid use disorder, and they experience the same analgesia as opioid naive patients with the usual analgesic drugs, including opioid analgesics. All right, now we're taking patients to the operating rooms. These are surgical patients. They're on buprenorphine for opioid use disorder, and they undergo surgery. Those continued on buprenorphine, as you can see in the right-hand column, do better in standard pain outcomes than the patients in whom buprenorphine was withheld. All right, so now you've got adults showing up to the ED saying, "Doc, I broke my arm. It hurts. Treat my pain." So bony fractures, and they treat these opioid-naive patients with buprenorphine versus morphine and find that buprenorphine is as effective and safe as morphine. Interesting. All right, this is what I am going to go into a little more detail than usual. Now we're starting to get into higher quality studies here. This is a randomized controlled trial. Looking at patients undergoing major abdominal surgery. So this clearly fits the category where these patients are going to require opioids. They're going to have at least moderate pain after the surgery. And they created 4 arms to this study. So these, to decode some of the jargon here, the arms are defined by the ingredients of a PCA, patient-controlled analgesia. So there's a bolus button and an infusion. And you can see that there's the first group there would be the buprenorphine bolus, buprenorphine infusion, and so on. All right. And as you can see from the outcomes, the buprenorphine won this walking away. So the pain was best. Patients were just hitting the button less in the bup group. They had higher patient satisfaction in the bup group. But as a side note here, I think if you were to review this study, you'd be surprised maybe that the authors put so much emphasis on the effectiveness of morphine alongside buprenorphine, illustrating, I think, what was present certainly in me and colleagues like me around this time, as I've said before, about there being almost a fear of buprenorphine in acute pain management. The other thing I want to just plant in your mind about this study, remember that name Oifa, the lead author. We're going to come back to this study when we think about what might be an optimal dose of buprenorphine around the time of surgery if we're going to try to make sure we're providing analgesia. Okay, and then to get even to a higher level of evidence here, now this is a systematic review and meta-analysis of RCTs that pitted buprenorphine against morphine for acute pain management in the hospital setting. So this is almost all surgery studies. There's an occasional study about like renal colic, kidney stone type pain, but the majority of the studies are surgical studies. And the authors found no difference in the primary outcomes here, including pain. All right. Here's some secondary outcomes. The first clump of secondary outcomes really are things we would just associate as a class with opioids. And if anything, there was a little improvement in buprenorphine. You know, if you've ever seen a postoperative patient who's suffering from itchiness, it can be very debilitating. So I'd say that's a good thing for buprenorphine. Score 1 for bupe. And then at the bottom, there might have been a little bit of a trend toward a longer time for patients to require rescue analgesia, but otherwise no significant difference in that secondary pain outcome. Okay, so I told you back 2016 that anecdote about that hip replacement that went bad, causing the surgeon to say, "Fix this. I don't care what you do, just get on the same page." So this reflects a local practice change that I think was reflective of the national trends. Okay, so the bottom line here is that the tangible benefits of continuing buprenorphine clearly began in our minds to outweigh any theoretical downside. The theoretical downside being interference with full agonist opioid analgesia. So despite, generally a lack of really robust prospective data, there was really rapid buy-in. And I think this is interesting to think about for a second, why there would have been rapid buy-in. I think from a prescriber's perspective, and a lot of you are prescribers, presumably in the audience, this was a simple and teachable thing. It reduced the risks that the prescriber was most concerned about, such as relapse and withdrawal, and provided a really easy mechanism to transition back to the usual dose. I think from a patient's perspective, they were enormously relieved. A lot of stress associated with coming off the buprenorphine. There didn't need to be a handful of oxycodone given to the patient in case of withdrawal symptoms, which probably wasn't a great situation for either the patient or prescriber. And then from the anesthesiologist acute pain perspective, as soon as we were reassured that we could provide really the standard care, we didn't really need to come up with anything heroic to control pain, I think it was fine by us too. So by 2019, we said we're going to continue buprenorphine perioperatively, but there still is this remaining question of what's the right dose, okay? Continue it, yes, but might there be a right dose that allows the continuation of its protective effects in opioid use disorder, but also allows for use of full agonist opioids for analgesia? And I would acknowledge right off the bat that we don't have a 100% right answer yet, but these studies are interesting. So this is one of a series of studies by Greenwald et al. Looking at tagged carfentanil PET imaging, querying the mu-opioid receptor at different parts of the brain. So this particular study looked at patients on buprenorphine, 16 milligrams a day, for their opioid use disorder, and looked at what he called the mu binding potential. But the other way to look at it is the mu receptor availability at intervals after their 16 milligram dose. So at the bottom, there's really no mu receptors available, whereas if you get 76 hours out, you see a lot of that brain lighting up. Okay, so I'm going to just tell you a few key takeaways from Greenwald and his co-authors here. So all that time, they were measuring serum concentrations and surveying the patients about their symptoms. So they found some insights into the therapeutic effect in opioid use disorder and found that withdrawal symptoms typically didn't come until about 50% of the mu receptors were available. Okay. And then there's a dose and time effect. And again, here we're trying to hunt that sweet spot where you're going to minimize your withdrawal and allow what some authors call a receptor reserve or full agonist opioid mediated analgesia. So a couple just things that were notable about some of the dose time relationship. Obviously, if I took a 32 milligram dose, there's not going to be a lot of mu receptors available for a long time. A 2 milligram dose, you'd expect considerably more mu receptors to be available. So I know this is nerding out a little bit here on this, but down here under dose and time, 4 hours after a 2 milligram maintenance dose, the patient goes to the PET scanner and they find about 60% are already available. Whereas about 4 hours after a 16 milligram dose, far fewer as you'd expect, only about 1/5 of the mu receptors available. So I'm just going to speculate here that it stands to reason that about 4 hours after a 4 milligram buprenorphine maintenance dose, you'd have about 50% of the mu receptors available. That is to say, you'd maintain some therapeutic effectiveness for opioid use disorder. All right, and I told you we'd come back to the OIFA trial. This is that 120 patients undergoing major abdominal surgery. So this is a little bit of back of the napkin pharmacokinetics. Acknowledge that, but extrapolating from that, some of that best prospective data for major surgery, their dosing scheme that provided effective analgesia was about a 3 milligram daily sublingual dose, which is pretty close to 4. All right, and as we said, 3 or 4 should result in about a 50% mu opioid receptor availability at 4 hours. All right, so a lot of these are popping up kind of based on a lot of this evidence that's been emerging since the mid-2000s. This is from a colleague that was part of our VA ECHO pain opioid core work group, Gregory A. Campora at MGH, who in his prior life was an anesthesiologist and is now full-time addiction psychiatry. So let's take a patient example and walk down this chart. So we have a patient undergoing laparotomy, thoracotomy, total knee replacement, something that's clearly going to be on the right-hand side of this chart. And let's say they're on 24 milligrams like my patient for the hip that I described earlier. Okay, well, daily dose greater than 8, yes. Daily dose greater than 16, yes. Okay, so all I'm going to do is say, Ms. Smith, the day before the surgery, you're going to go down to 8 BID. All right, Ms. Smith, on the day of the surgery, you're going to go to 4 BID. I'm going to tell the surgery team, all you got to do is continue 4 BID throughout the whole surgery. Even if they have a Whipple and can't take anything PO, they can still take sublingual bupe. And then basically they're going to be discharged with whatever usual opioids the surgery team would discharge their patient on. And basically, as soon as they're off, they continue that 4 BID. And then as soon as they're off their full agonist opioid prescription, they can resume their usual bupe dose. And these are popping up here and there. There is some preliminary evidence, no great randomized trial to really support their use, but some indications that length of stays are reduced, opioids are reduced when patients on buprenorphine are managed in this way. Okay, so another head scratcher, what do you do about extended release buprenorphine? So you all probably have patients on this. I've been thinking about it lately. And when patients are on a steady state of buprenorphine, it lasts, of ER buprenorphine or Sublocade, it lasts a long time. All right, you know the regimens. Typically, patients are going to end up on a 300 or 100 Q28-day regimen. And I just want to break a little bit of this out in the table. And we've talked a lot about sublingual buprenorphine and the Greenwald studies and all that, but here's some just average serum concentrations that are in the literature for sublingual bupe, and you can compare it to extended release buprenorphine. And you can look at the mu receptor availability. So even on a lower ER buprenorphine dose, you're maintaining a relatively high serum concentration and relatively low mu receptor availability compared to the patient on sublingual bupe. Okay, is that a problem? We just really don't know. And I'll also just point out, as I did at the beginning of this discussion about what the right dose may be, I know there are plenty of providers out there that just say, don't change the bupe at all. In fact, maybe increase the bupe. And that may prove right. And if it does, I'll be delighted because it would greatly simplify all of this. But as you can see with the extended release bupe, as I said, we're talking about relatively high concentrations and relatively low mu receptor availability compared to the sublingual. And this is just it in graphic form. So the blue curve here is going to show the predicted median buprenorphine concentrations after 100 milligram and 300 milligram monthly buprenorphine injections. So you can see a steady state 4 to 6 injections in. The red and green lines show what happens after a holiday. And after a holiday, what you can see is not much happens. You maintain those buprenorphine levels for a long time. And similarly on mu opioid receptor, this is the same model that predicts mu receptor occupancy after dosing of 100 and 300 respectively. And what you can see is really you're occupying all those receptors for a long time with very little variation, other than maybe right around the injection where you do get a spike. So best practice, I don't think anybody can tell you with a high degree of confidence what the best practice is. One thing we know for sure, that having a plan is a good thing. Having no plan is a setup for failure. So I think a multidisciplinary approach involving the prescribers as well as the acute pain teams, potentially with pharmacy. Pharmacy is always great to have on the team. Involving surgeons is always good. And then the reasonable idea, and there's some anecdotes for this that is, largely case report, case series type information, that just scheduling surgery at the trough, that is to say at the time of the next scheduled dose, is reasonable. And that's it for me. So let's see. Oh, this is transitioning over to Caroline. So what I'm going to do is hand controls over to you, Caroline. See if I can manage that.
Okay, great. Thanks, Tom.
Heidi, I'm dragging the thing. Yeah. Yes. Should have control with the page up, page down, Carolyn.
Okay, let me see here. Yes, perfect. Thank you, Tom. Can you guys hear me?
Yes.
Okay, thank you so much. That was an awesome intro. I love getting to work with Tom again. We're going to go through a couple cases. I'll make sure to finish this part by 11:45. When we've done the cases in the past, we did have interaction from the audience, but I know that's not ideal with this setup. So if you guys save any questions you have for the cases, we can do them at the end. Okay, so the first case, the consult question was recommendations for buprenorphine adjustment before dental surgery. So HPI, this was a 64-year-old guy, opioid use disorder in remission, chronic low back pain, was taking buprenorphine naloxone combo, so the 24 6 milligram total daily dose. And he was scheduled here for an elective dental procedure. So he was stable on buprenorphine, and how do we know that? No opioid cravings, no aberrancies, no return to non-prescribed opioid use, and then overall his chronic pain was very well controlled. So what about relevant history? Has a history of coronary artery disease, hypothyroidism, spinal stenosis, and that was the trigger for the chronic low back pain, opioid use disorder and sustained remission, and also alcohol use disorder and sustained remission, and not on any pharmacotherapy for alcohol use disorder. So he lived with his wife of 40, more than 40 years, had an adult daughter, had some siblings, had good social supports. Just like any relevant social in this case, had completed 10th grade with a GED, been working as a chef, but he was now on disability. He was Protestant but wasn't practicing. And then he did have a very strong family history of alcohol use disorder. I only bring that up just because these are important considerations, especially when you're thinking about peri and postoperative pain management, but certainly shouldn't be changing analgesic plans. And so as far as medication, we did talk about the buprenorphine. So he was taking a total daily dose of 24 milligrams. It is relevant to know that he was doing it with 8 TID, so was not taking the entire dose in the mornings. That was because it was co-treatment of both opioid use disorder and chronic pain. Aspirin 81, levothyroxine, and fish oil. He was doing some private counseling. He had done a couple inpatient alcohol treatment programs, and those had been multiple episodes, but the last was like more than 2 decades prior. All the labs were as expected. The urine toxicology only showed buprenorphine, which was expected. And so what happened for the dental procedure? So this happens a lot with our patients because they don't get dental here, within our health system. So you don't typically know what's actually going to happen. You don't know the extent of the surgery that's being planned. You don't know the extent of the pain that, should be expected. So you just kind of have to do your best guess. But based on, we did speak to somebody at the dental office, it sounded like if you're thinking about that algorithm, mild pain, not moderate or severe was to be expected. This is honestly probably more conservative approach than we needed to take. But, if you think about that fork in the road, if it's a mild pain expected procedure, you actually don't need to make any adjustment in the buprenorphine regimen. However, we did. So the baseline we know was the 8 TID, so 24 total daily dose. The day before the procedure, we still had him do the 8 TID. Day of procedure, we had him go down to 8 BID, so only a total of 16 total daily dose versus 24. And then after the procedure, we just had him resume the next day back to the TID. And in this case, he only required 2 doses of the oxycodone on the day of the procedure, none the day after. And this was actually less than expected. So at this point, the dental practice had said like oxycodone for a couple of days following was typical of their procedures of this magnitude. And funny enough, actually, this patient said that the day after, or no, the day of, he said the buprenorphine actually treated the pain better post procedure than his oxycodone. So they had given him a couple days worth. He only took 2 of those doses and just went back to his bup. And then as far as non-opioids, acetaminophen, and then just like the typical additional interventions like the ice packs. And I just put that in the chart just to remind us that like there are so many other ways that we're treating pain that are important that we can't forget in these sort of perioperative, postoperative situations, that sometimes we start to lean a little bit too much on the opioids, whether partial or full agonist, but knowing that there's all of these like essential components that Tom was mentioning, the big three. Okay, so the next case, perioperative buprenorphine Rex for patient undergoing cardiac valve replacement. So if we're thinking about that chart, this is like on the opposite end of the spectrum. So not a mild pain procedure, this would be moderate to severe. So in this case, it was a 35-year-old patient, had severe opioid use disorder and injection drug use related infective endocarditis, so infection of the cardiac valves. And this patient had been admitted to the hospital and was scheduled both for an aortic and mitral valve replacement. So she'd initially presented just with like constitutional infectious symptoms. Notably, she'd been injecting 15 bags of heroin daily for the last 8 months, but had a history of opioid use that had dated like 10 years prior. She was prescribed buprenorphine 24 milligrams a day, the buprenorphine combination, but hadn't been taking it consistently leading up to the admission. So at the time that we were seeing her, she'd been in the hospital about 2 weeks. She'd been stable. They had restarted the buprenorphine, was taking 24 milligrams total per day, and then was scheduled for surgery in 2 days. So we went over some of the relevant diagnoses: infective endocarditis, MSSA bacteremia, severe opioid use disorder, and a likely anxiety disorder. So she didn't have a ton of social supports, had a lot of housing insecurity leading up to the admission. And again, none of this should be changing the analgesic plan, but just thinking about what are the situations and what are the environments that patients are going to be discharged to. She had completed high school, had some limited college, but stopped, due to her substance use, and to the, at that point had already developed a substance use disorder, and had been working at a veterinary clinic, but wasn't employed at the time of the admission, and no relevant family history. So we talked about the buprenorphine. So this patient was on 24 milligrams total daily dose of the combination, was taking gabapentin, was getting nafcillin for the MSSA bacteremia, and then also was taking already the acetaminophen. So not currently enrolled in any kind of psychotherapy, had been getting some at various points during the 10 years of substance use. And then in terms of relevant labs, she had stable renal function, stable hepatic function, had a leukocytosis in the setting of her bacteremia that was improving. And then the urine toxicology on admission was consistent with the history. So opiates positive, fentanyl positive, and benzodiazepine positive. So what happened with this procedure? So if we remember back to that algorithm and to that first fork in the road, this is the moderate to severe expected pain-related procedure. She was going in with 24 milligrams total daily dose, got that still the day before the procedure, and then the day of the procedure went to 8 TID. I'm sorry, this is a typo, because she only actually got 2 of the doses before the procedure. So she was towards the end of the day. It didn't exactly align, I think, with what Tom was saying about some approaches are to do the surgery around the time that you'd be due for your next dose. It didn't align exactly as such, but she did get 2 of her doses. So had gotten 16 of the 24 in that day. Underwent the procedure. During the procedure, got IV hydromorphone, IV fentanyl, additionally got IV ketamine, and I'm not going to go into the details of that, but there was just adjunctive medications being added. This was one of the first cases that they had done of the valve replacement on a patient with higher doses of buprenorphine. So I think there was a lot of additional adjuncts that were being tried, just because there was some fear, I think in this case, of inadequate analgesia. And then the day after the procedure, she went right back up to 24 milligrams of the combination and was able to switch to the PO hydromorphone, got IV NSAIDs, and did really well, had no issues with pain control. And then going forward, was able to still continue on the 24 of buprenorphine, ended up on oxycodone only for 5 days, tolerated a taper very well. And then was getting, the NSAIDs, acetaminophen, and then PT, and just getting out of bed, I think was actually also really helpful. And then the third case, so like we wanted to make sure to touch on one with extended release buprenorphine or Sublocade, just because, probably more and more patients will be presenting on Sublocade and undergoing either elective or non-elective procedures. But in this case, it was planned. So this was a patient on extended release buprenorphine, and the consult question was recommendations for upcoming CT surgery. So it's 37-year-old patient, had a history of remote infective endocarditis, had a tricuspid valvectomy actually at the time, and so was now presenting for a planned tricuspid valve replacement. So had the tricuspid removed and was coming, more than a year later for tricuspid valve replacement. And this patient was maintained on extended release injection buprenorphine. And so again, planned procedure, not unscheduled. And at the time of the surgery, the patient was on buprenorphine 100 milligrams sub-Q once monthly. So the dose ranges are 300 to 100. Some patients get 300 the first couple months and then go down to 100. Some do stay up on 300. But if you remember one of the charts that Tom was showing, the buprenorphine, if you're doing 100 milligrams extended release, you should expect about 40% of the mu opioid receptor availability. So that's where this patient is falling. And so what happened? So they were able actually to schedule the surgery so that it was occurring on day 28. So the patient, this is this is a curated, planned procedure with a patient that was stable in recovery. So they were able to do this. I think like all the stars had truly aligned. It doesn't always happen like that, obviously. But that's what they did. So they scheduled the surgery for day 28. So the baseline regimen here you see is the 100 sub-Q once a month. And then day 27 corresponds to the day before the procedure. So what happened on the day of the procedure? They went to 4 TID of sublingual bupe. So no additional Sublocade given on this day. Got still like the high affinity IV opioids and did totally fine. And then day after the procedure still was on sublingual and then transitioned back to Sublocade. And this patient did really, really well. The PO oxycodone was able to be tapered after a week and utilized the NSAIDs and acetaminophen. So let's see where we are for time. Oh, actually, we're really good for time. I can actually hover on this chart if that's helpful. So that's it as far as the cases. I probably went through them too quickly since we actually do have a little more time, but.
You never get
That's
penalized.
okay, you all have.
Caroline.
Can you all hear me?
Yes.
Yeah. No, this was a wonderful presentation. Thank you so much. And I really enjoy hearing about the case presentations because I think it brings to life the recommendations, and also you get a sense of the care that you take with each patient and how detailed it is in terms of their specific situations and making those changes. It's really quite interesting and really impressive. I want to just encourage the audience to write in with any questions. We do have one, which is, do you have any recommendations for transdermals?
I mean, you go ahead, Tom.
I never really thought about that, Caroline. What about you?
Yeah, I mean, so we have had patients on, like, I'm assuming, well, oh, actually, I was just thinking buccal when you were saying that. I haven't actually had any cases like that either where we've stopped it. They've been such minor things, though, in the transdermal, the dose is relatively low. Again, obviously, people on transdermal, they would not be taking it for opioid use disorder. This is for chronic pain. It's a much lower dose. But yeah, no, we haven't had any interruptions in that for any procedures that I've been involved with.
I was wondering, I was so impressed with, the evaluation of the patients and how detailed the recommendations are. And I'm just wondering, if you do anything that's standardized or if you've given any thought about what it would be like to evaluate the patients, afterwards to see both how they're functioning, what the experience was like for them, and maybe even what the experience was like for their family members.
Tom, do you want to speak to that first, and then I can talk about, when I've seen sort of the weeks later?
Yeah, absolutely. So let me try to touch on that transdermal, because what I did, Caroline, is I pulled up our MCNA paper, and we put in a little chart where we put sublingual dosing approximations for alternative formulations. So even at the highest transdermal patch, which would be about a 20 mic per hour, at least according to this table, that's approximately equivalent to about a milligram sublingual bupe. So I
Hmm.
think, you'd be operating in that area where, based on this, what I admit to be a little hand wavy idea about all the mu receptor occupancy, all deriving from a lot of this PET studies, you'd have plenty of availability of mu receptors for whatever opioids you wanted, and maintaining some analgesia from bupe. So that's one thing. I think Robin's idea about really studying this thing to get beyond sort of anecdotes about how happy patients were would be great. I think just in terms of my own personal experience, I think patients are enormously relieved right from the get-go to be able to stay on their buprenorphine, and they're fine with minor adjustments. I think it's
Hmm.
the prospect of being off it that's a little frightening. And I think when you have a patient who's already frightened and anxious going into a surgery, that's just a bad prognosticator. We know that it's a bad prognosticator for pain after the surgery. You see
Yeah.
just the extreme example of that would be catastrophizing, and that is like a really terrible risk factor for poorly controlled acute postoperative pain in patients that really don't need to have terrible acute postoperative pain. So yeah, I think you'd find without much work there, if you were to survey these patients and their families, very high satisfaction. That said, you wouldn't really have a comparator group necessarily unless they've historically had the other type of management, which would be abstinence from bupe.
Right. It'd be also interesting for, the other caregivers around, nursing staff, because if they have patients that are less anxious, I'm sure it, makes their job easier and they're less likely to, I don't know, give other things that might be around.
And like it's a really nice workaround, in the immediate post-operative phase too, because even if a patient is still MPO, they can still be taking the sublingual. Nothing is going down into their stomach, and we encourage patients to kind of spit out any residue after 10 minutes or so. So it's, it also allows you to keep this base and not rely solely on IV opioids immediately post-operative as well. I think the problem that we encounter is patients that have been stopped, so their full agonists have been stopped, and then trying to get them back onto buprenorphine as an outpatient. It is so hard. You're never aligning it perfectly. There's always this period where obviously somebody is struggling either with now their kind of untreated opioid use disorder plus access to full agonists and at times not using them the way they're being prescribed. And how do you overcome this bridge with now the postoperative pain and trying to restabilize somebody? It's not to say that every single patient becomes destabilized in those situations, but we're setting everybody up for failure by removing their consistent pharmacotherapy, fully.
Right. So, how widely is this being done, the perioperative buprenorphine, and are people writing about it and doing studies so that the practice does spread, or that there's more evidence about its safety and about, some of the positive outcomes that you shared with us?
I think when we got together our work group that I mentioned at the onset, we were really excited we would be breaking new ground, and we found pretty quickly that we were just piling on to kind of a large group of what are admittedly a little bit of thought pieces, reviewing case reports and case series more than anything that's really robust perspective data.
Mhm.
But we were maybe the 10th, no, maybe not the 10th, but like the sixth or seventh similar piece in reputable journals that were suggesting this simultaneous strategy. That is to say, buprenorphine and full agonists together. So yeah, I think it's out there, and I hope it's becoming the norm. I wouldn't know how to answer that question in the literature, though, Robin. That's a great one.
Yeah, I mean, I just think what you're doing is so exciting, and so the more evidence you can get out there about it would be great. Okay, so we have some more specific questions. Any precipitated withdrawal cases? No. see a head shaking. Okay, great. Any
I would
suggestions
think
on how to get?
Caroline would be able to answer that, I think, better, but I think she could probably tell you about some precipitated withdrawal cases from the old way we did things, right, Caroline? Probably when you're
Yeah, yes,
that's
absolutely. So I think that if you're switching off entirely, then you are setting yourself up for that kind of a risk. Especially if you don't think that you're going to be able to come up either with a clear taper of a full agonist or a taper down and slow reintroduction of the partial agonist. I think also in practice, we're also moving a lot towards the overlapping or micro inductions, another term for it, but slowly going down on full agonists and introducing partial agonists like bupe. So it does reduce the likelihood of precipitated withdrawal. Yes, things just get messy when bupe is stopped. And so having it be continued certainly reduces the incidence. But none of the cases that we've worked on that we did during my fellowship, and admittedly, that's not a lot. So like I'm really new in my training. I only just finished fellowship over the summer last year. But we didn't experience any precipitated withdrawal cases for perioperative or postoperative patients.
Do you have difficulty getting staff comfortable with this or educated about this, surgery or inpatient staff? And somebody's asking, do you have any suggestions for how to get surgery and inpatient staff comfortable with this? Sorry about that.
well. We have our experience here that sort of prompted my interest in this whole topic. I never thought in my residency I'd be here talking about buprenorphine, not in a million years, right? But things happen. So, and I'm delighted to be. Don't get me wrong. I think it's my favorite drug currently. Which I don't know if people know, but anesthesiologists, we basically give drugs all day. So if it's my favorite drug, that says a lot about bupe. Little medical humor here. So, so in my personal experience here, like I said, I think it was remarkably easy because it really aligns incentives if you think about it. So in the old method, Caroline and I might talk, might not talk, but our incentives are totally at odds with each other because I'm sitting here thinking she's trying to screw up my acute pain management, and right, and then she's thinking, oh, this patient's been a nightmare, a nightmare. Not that she'd ever say that about a patient, but so worried about this patient withdrawing or relapsing. And God, the last thing I want to do is give this patient a prescription for a full agonist for that stupid 72-hour window. So we were like this, right? We were at odds with each other. But now with this, incentives really become aligned. So I was alarmed, and put this in the context of the VA. There's a lot of people out there, and I love the VA, and I'm a big cheerleader for the VA, but change sometimes is very slow, right? It is. I'm sorry.
Yeah.
So this was really fast, actually, and I think that's the reason, because everybody just kind of saw the light. It just makes sense. Provided we have that accumulating data to reassure people like me that pain management's not going to be a nightmare. And once we felt like pain management was going to be just fine, it was great. We do in our manuscript have recommendations for, outpatient clinicians to be providing patient education, telling patients about the algorithm if one exists, talking about goals, communicating with the surgeon anesthesiologist, and then engaging the inpatient people, including the inpatient addiction medicine or addiction psych, including pharmacy. Pharmacy can be awesome in these. I mean, they're really the experts in a lot of this stuff. They can provide so much care coordination between all the different groups, two of which are in the operating room all day and often can't even be reached. And then all the way to the discharge clinicians who are really going to have to just set up the outpatient support too, and make sure there's follow-up with the regular prescriber. So that's in the manuscript in the MCNA. People can look at it in more detail, but really, I think more so than any particular management strategy, just engaging a team in your hospital. Another just bit of context that might help people is, this is a little beyond the scope, but there's an enhanced recovery after surgery paradigm that's really catching fire. That's been around since the 90s, but we've, in a lot of respects, been slow adopters. But essentially, this pulls together best practices to get patients out of the hospital quicker, including things like making sure they get multimodal analgesia. But if that discussion's going on in your hospital, it's yet another way to jump on and push ideas like maybe we should think about the way we do buprenorphine. So yeah, a little beyond the scope of the discussion, but had to make a plug for that. Anyway, you
Yes,
can get this conversation started about bupe is a good thing.
People are asking about whether the presentation will be available. It will on the HSR&D CIDR website. There are pull-down menus where you can go to the different cyber seminars. Ours is Spotlight on Pain Management. You can go to the archive and you can see any of our previous talks. It might take a day or two for this one to be posted. Also, might our presenters be able to share a link to your manuscript and to the conversions for bupe? We're being asked about that. Let me see, we've got a few more specific questions. Regarding case number 3, when ER bupes restarted post-surgery in relation to full agonist taper, I don't think I fully understand that.
Wait, sorry, that was at the end of the question, just in terms of
Yeah, I'm
timing,
not
is
sure.
that it?
You know, I'm not sure I fully understand, but this person did have another, I don't know if it's another question or continuation regarding transdermal bupe, typical 7-day treatment. Does pharmacokinetic data support a strategy to plan surgery on day number 7?
Oh, that's interesting. Like they're asking about a Butrans patch, for example, and like, would you time the surgery? I think that would be unnecessary because of such a low dose of buprenorphine. And again, like Butrans, this is for in the setting of chronic pain, not opioid use disorder. The doses are much lower. But Tom, I don't know what you think.
Yeah, I don't really have anything much more to add than that.
Here's another one. Were you able to determine whether any of the patients who had epidural blocks plus bupe did better or similar with their post-op pain?
I don't think we have any sample there of epidural cases that I'm aware of. Epidurals are still considered kind of a gold standard for pain management for bigger abdominal or thoracic surgeries. Rarely the sternotomy patients like what Caroline described, though. That hardly ever happens. But generally, the practice is moving away a little bit from epidurals. There's just less and less of a sample size. And I just am not aware of a lot of cases with epidurals. But there's nothing in my mind that wouldn't lead me to believe that those two would be totally compatible therapies, buprenorphine and a neuraxial anesthetic or epidural analgesia.
Yeah. I'm just wondering if the two of you have any thoughts about, future directions for this work, for the VA, for the larger healthcare system.
I
do, but I've been stepping on Caroline. Let me give her a chance here.
Oh my God, not at all. Not at all. No, I mean, I think, and I feel like we would both say this, is that the simpler, the better. And anytime we can continue people's chronic medications, the easier everything is. I mean, you think about it with anticoagulation and anything. I mean, the closer that we can get to people's chronic stable regimens, the better. And the reducing the number of days that are a disruption from that. And I think that just goes uniformly to anything. And just like not forgetting the power of acetaminophen and NSAIDs and the blocks when they're appropriate, and also, feeling empowered to, if you're the buprenorphine prescriber on the outpatient, feeling empowered to make recommendations within the, the realm of what's been published, and also having close follow-up with your patients to make sure that they're stable.
Yeah, I think one of
things you would like. Yeah, I was just going to ask if you had anything you wanted to add, Dr. Hickey, before we wrap up.
Oh, yeah. Well, I think it's an interesting thing to think about. We have this drug. You'd think if it were started perioperatively would reduce the likelihood of persistent post-op opioid use, at least in my mind. And lo and behold, it's a really good analgesic medication. And a lot of the literature shows that its side effect profile when it comes to opioid-related side effects is actually better than everything else.
Mm-hmm.
So my answer to Robin would be geez, why aren't we starting it in patients? Why aren't we starting it in patients and using it? And there you could think of, this is clearly in the half-baked idea category. I totally own that. But like, what about if I come in for a knee replacement, start me on 4 BID of buprenorphine and keep me on that until I'm done with my whatever full agonist opioids I need. I bet if you had a big study that way, you'd find good analgesia, reduced side effects from opioids, and reduce persistent post-op opioid use. And maybe you just put a little dent into the surgery world's contribution to the crisis by doing that. So
Yeah.
just, it's an idea. It'd be fairly easy to study. We're trying to get something like that going here, a little pilot program. And maybe it'll expand beyond that.
That would be wonderful. Maybe you could tap into resources at the Prime Center at VA Connecticut. Get some small grant funding to get that off the ground. I know we would love to see that. Thank you so much for such a wonderful presentation and for the work you're doing. It's really incredible. And thank you to our audience for tuning in today and writing in with some great questions. It made for a really interesting discussion. Just one more reminder to hold on for another minute or two for the feedback form. Our next cyber seminar is going to be next month on Tuesday, May 3rd. We'll be sending registration information out around the 15th of the month. And I just want to thank you again for attending this HSR&D Cyber Seminar. We hope that you'll join us again.